Thank you for that lovely welcome, and thank you for asking me back. I'd like to begin today by acknowledging the Gadigal people of the Eora Nation and pay my respects to their elders past and present, and also acknowledge those with lived and living experience of mental health conditions. It's an honour to be here today, to be given an opportunity to share my thoughts on the things that bring us together. I'm not a natural contrarian, but when I was asked to speak on this theme, I immediately began to think of the things that might set us apart. As a lawyer member of the Tribunal, tasked with making decisions about whether consumers should continue with involuntary care and treatment, I have seen many consumers leave hearings not having succeeded in their quest for discharge. For someone who is the recipient of an unwanted order, it may well feel to them and their carers that their opinion was not valued or heard. For those consumers who've had successive community treatment orders, it may feel like a hopeless David and Goliath battle to be free of enforced treatment. This view might be reinforced by a straw poll of the 3 top issues in a hearing. My observation is that in the tight time frame of 30-minute hearings, the main 3 topics centre on diagnosis, risk, and reviewing, reinstating, retrying, returning, re-challenging, now I've run out of our words, some kind of medication. The medical model is queen. Tribunal statistics show that the vast majority of applications for involuntary care in the community or hospital setting are upheld. This is even if consumers are legally represented. For some consumers, not all I have to stress, because there are also many consumers who during periods of great distress find care and treatment helpful, but for other consumers, they may well be a sense that their interests and those of the tribunal are far removed from their own. For some, it might even appear that the tribunal is just a rubber stamp for the treating team's views. For a fledgling consumer workforce trying to make inroads into the hallowed halls of psychiatric practice, it may well seem a daunting task to reorientate focus onto the needs, preferences and wishes of consumers and their carers, and not merely adhering to an old medical model. Levelling the playing field by representing the will and preferences of consumers and by seeking that their views are seen through the lens of lived experience may seem like a very difficult task. But there is a common thread that unites us and that brings us here together today, and that is, I believe, a commitment to realising the rights of consumers who are navigating the mental health care system, and in particular, involuntary care. From the moment of an involuntary admission to final discharge of a consumer's order, the Mental Health Act enshrines certain rights. From the person who writes a schedule, to the ambulance officer who transports the person, to concerned carers, clinicians and consumer workers, each of their actions should be based on the following: timely access to appropriate care and treatment that is based as far as possible on the consent of consumers and in a way that causes the minimum interference with their human rights. Involuntary treatment should be the treatment of last resort. Furthermore, treatment should be recovery-focused, trauma-informed, and restore a person's autonomy and full citizenship. The principles of care and treatment in the Act and the objects of the Act reinforce the primacy of these rights. Safeguarding rights is a shared responsibility because a consumer experiencing distress may be unable to assert their rights at the very time when those rights may be most vulnerable to being breached. People experiencing acute distress may be confined or treated against their wishes, which can be a serious threat to their rights. And while we might know intuitively that working in a rights-based recovery model is good for the consumer, and by extension good for psychiatric practice, it is worth noting that research confirms that the best outcomes for treatment and consumer satisfaction occur when human rights are upheld and treatment is recovery-focused and trauma-informed. The rights set out in the Mental Health Act derive in part from the UN Convention of the Rights of Persons with a Disability. Their aim is to set standards for equality of access to health, freedom from discrimination, and protecting the dignity, respect, and autonomy of consumers. However, it is important to be clear that the Act balances rights with other considerations, the most evident being that involuntary care and treatment may be given if the statutory tests of being mentally ill or mentally disordered are met. So as we go about our respective roles, it is important to hold these rights front and centre. Consumer workers, I believe, should not only have a good grasp of what those rights are, but should also be part of their practical application. This falls into the other side of the ledger, the duties and responsibilities owed to consumers. So what are these rights? The Mental Health Act refers to a myriad of rights that I think can be distilled into three main themes, and they are these: the presumption that consumers can consent to treatment and that they are to be consulted about their choice of treatment; the right to procedural fairness; the right to access health care that promotes self-determination, recovery, inclusion, and full citizenship. Let's start with the presumption of consent to treatment by the consumer. The Act states that every effort should be taken to obtain the consent of consumers to treatment and recovery plans, to monitor consent, and to support persons who are unable to consent to understand those plans. This involves taking all practical steps in helping a person to make a decision concerning their treatment, and requires an assessment of the consumer's understanding of the information relevant to the decision, retention of that information, the ability to use or weigh that information as part of a decision-making process, and to communicate that decision. Even though the Act seeks to qualify this right by stating that every effort that is reasonably practicable should be made to obtain consent to consumers, treating teams are obliged to check whether capacity exists and cannot assume that it does not. If a person is unable to consent to treatment, every effort should be made to support the person to make treatment decisions. A rigorous process must be followed in each case, and in each case the issue of consent should be clearly documented. Consumers are likely to achieve successful outcomes if they participate in their own treatment, but this may not be possible at those times when they're extremely unwell. A way that a consumer's preferences can be respected is by a living will or an advance directive. These are not new ideas. In 1987, Dr. Meg Smith, consumer, speaking at a national conference on mental health services at the University of Newcastle, discussed what could be included in advance directives. She identified treatments to which one objects. Dr. Smith reported that in her case, haloperidol had dreadful side effects, while another medication, clonazepam, was much more pleasant, had fewer side effects, and work just as quickly as haloperidol. The process of making a living will was summarised by Dr. Smith as a powerful way of accepting ill health and putting it into some context. In her words, "I don't think very much now about impending illness or worry about what is going to happen if or when I become ill. Like my other will, it is tucked away to be activated when necessary." A living will could alleviate the stress of an admission by setting out the activities or therapies of preference, people to be consulted or not, employment and study, the role of family, and what will happen to a consumer's children. Dr. Smith offered practical advice to people thinking of making a living will, which remain relevant today. Research the current service system. Choose a couple of hospitals or places where you can be cared for. Pick some good friends or carers to carry out your wishes. Who do you know who is strong, determined, articulate, and persistent? Find out about new treatments and services. Talk to other consumers. Educate your health care workers. What are their attitudes? To that list, I would add, seek out a consumer worker and formally involve carers in supporting treatment decisions by nominating up to 2 designated carers. On this point, it is not clear to me that consumers know that they have the right to nominate up to 2 carers, or that the right extends to community treatment orders. I do know that some mental health facilities do not appear to be across the entitlement. On more than one occasion, I have been met with what might be politely described as a state of deep unknowing and or mild surprise when asked if a nomination was made. What is also not well understood is that if a person is too unwell to make a nomination at the time of an admission, the issue should be periodically revisited by the treating team such that the nomination can be made when a person is able to. This is because a person's capacity to make a decision may fluctuate and is decision specific. As participants in the system, we must all recognise that self-determination is a vital part of successful treatment and recovery. Efforts to restore consumers' capacity to make decisions is also a key part of treatment. The right to procedural fairness, that involves 3 main tenets: the right to be heard, the right to have the decision based on evidence, and for it to be free from bias. Procedural fairness operates from the moment of any assessment for involuntary detention. Procedural fairness is pertinent to all decisions made during a hospital admission, including the decisions of the tribunal. The Act embeds this procedural right in a number of ways. For example, a consumer has the right to access their medical reports before a tribunal hearing. On rare occasions, access may be denied to some or all of the report if there are compelling reasons related to the consumer's safety or the safety of others. As soon as practicable after a person is detained, they are to be given an oral and written explanation of their rights in a language they understand. This does not mean just handing out the form and hoping for the best. If the person was too unwell to understand the explanation, I'm going to be more than 1 minute, sorry. If the person was too unwell to understand the explanation, the contents must be given at least 24 hours before the first hearing before the tribunal, known as the mental health inquiry. After the hearing, the person must be given an explanation of their legal rights. Consumers in the first year of an involuntary admission have a right to access free legal representation through the Mental Health Advocacy Service. Lawyers representing consumers should be given open and unfettered access to reports well before the hearing day and on the hearing day. There should be fair notice given of the date and time of a hearing, with an offer to organise the consumer's supports, which may also include their participation in the hearing. Crucially, consumers should be supported to participate in their hearings. They should know what to expect at a hearing and understand that their views count. The Tribunal's website has a training tool, a video of a hearing that can be shown to consumers. They should be encouraged to set out their views in a self-report form, also available on the website. They should be given fact sheets about the orders being sought and know that they can request an adjournment or have the right to an interpreter. They should be given a safe, quiet space to prepare their words and an appropriate place to wait in before a hearing. They should be given an opportunity to raise concerns about any report and have them corrected before the hearing. They should be given an opportunity to debrief and provide feedback after a hearing. In practice, I would hope that treating teams guided by consumer workers would encourage participation by facilitating these things, as well as explaining why an order was sought and engaging in a dialogue that genuinely seeks to understand and respond to the consumer's views and preferences. These are discussions that should occur throughout the admission, with plenty of notice given about a tribunal hearing and an offer to involve carers, family, friends in any discussion. The point is, no consumer should ever be taken by surprise by evidence given at a hearing. The right to access health. This is a biggie. We all know the dreadful statistics in relation to the health outcomes for persons living with mental health distress. On every measure, consumers are missing out. The Mental Health Act frames the right to access to health as follows. Consumers are have to have access to the best possible care and treatment while interfering minimally with their civil rights. Care must be timely and high quality that accords with professionally accepted standards. It must be recovery focused. I would interpret this right to extend beyond mental health care to include all of the consumer's healthcare needs. Again, this should be negotiated with the consumer in an open and transparent way that takes into account their views and preferences. In recognition of this need, New South Wales Health has issued a physical health care for people living with mental health issues guideline for New South Wales Health Services. The document reinforces the obligation to improve physical health outcomes and reduce early mortality for people living with mental ill health by mandating routine physical screening, identifying health risk factors, highlighting opportunities for change, triggering follow-up assessments, referrals and support, and providing an early opportunity to intervene and improve physical health outcomes. Not all consumers will have carers, and in instances where a person lacks capacity to make treatment decisions, the Guardianship Act provides a consent regime. Its legislation emphasises the role of support to assist in making decisions. The right to health should also extend beyond the walls of a mental health facility and orders of the tribunal. It should include psychological support, support with restoring living skills, accessing education, employment, maintaining physical well-being. The right to health is just not medication. I'd like to suggest that we are bound by a common purpose, and that is to realise the rights of consumers. The law has changed at a relatively slow pace to embed these rights into the legislation, and while it is not perfect, the focus of the tribunal is on the rights and interests of consumers. There are a number of tribunal initiatives that we are pursuing to realise these crucial objectives of realising, protecting and implementing consumer rights. COVID interrupted tribunal hearings, and those that took place during the most serious part of the pandemic were by video conference. In many ways, it only served to emphasise the challenge of doing therapeutic jurisprudence behind a screen. Having a physical presence at a hearing is an important priority. We have recently recruited members in some regional areas so that the first hearing, usually conducted by a single legal member, is in person. We are working on a plan to recruit in local areas to have at least one member of 3-member panels attend in person. We are working on a 4-year strategic plan that will digitise records and allow for paperless hearings as a way to have more efficient and accessible hearings. Papers for hearings can be sent directly to the member's email and downloaded for hearing. This will assist in facilitating a physical presence. We have commenced keeping better data on carers' involvements in our hearings, as well as the input of consumer workers. We are also working towards a plan of creating a Tribunal consumer and carer advisory group that will bring to our work and processes your expert input. As consumer workers bringing your rich expertise to the table, you offer a lens to advocate with consumers from within at both an individual level and at a systemic level. I'm nearly there. Consumers who are subject to the Mental Health Act are entitled to expect that interventions will be provided in a framework that upholds their human rights and promotes their health, well-being and recovery. I'm not suggesting that health facilities are dismissive of consumer rights, but in the context of busy wards, more people than beds, fragmented discharge planning, the fundamental rights of consumers can be overlooked or not given paramount consideration. Realising rights with the principles of recovery requires a collaborative approach. I'd like to think that today we share another thing, and that is an aspiration that working in a human rights-based framework will eventually lead to wholesale systemic change. I close today by endorsing the words of 3 authors, Marks, Vermeil and Willis, in a 2019 paper entitled Human Rights and Mental Health. They say, while consent to treatment is a critical human rights concern, a disproportional focus on it perpetuates the perception of persons with mental disorders as risky and out of control. Part of the solution to this dilemma is to move from a reactive approach when the person is already too compromised to consent, to a preventative and proactive approach, which is community-based, emphasising alliance rather than compliance. Care should go hand in hand with community education on mental health and human rights, as well as opportunities for participation in community common goals and involvement with other persons with lived experience. Thank you.